A warm welcome to this presentation on Wilson disease. My name is Karl Heinz Weiss and I'm an adult hepatologist based in Heidelberg, Germany. Today, I want to introduce you to the disease, the road to diagnosis, current treatments, and discuss with you recommendations for patients living with Wilson disease. Let's talk about Wilson disease, a disease of liver and brain. Wilson disease is named after Sir Kinnear Alexander Wilson, a neurologist who lived in London more than a century ago. He noted in some of his patients that they have symptoms related to two organs. On one hand, advanced liver disease, and as a neurologist, for him even more obvious, symptoms that disturbed motor function. Patients were shaking, were atactic, could not walk, some could not even swallow properly. He further recognized that this patient came from same families, so he already suspected that this is an inherited genetic disease. There were not few of these patients, and later on it was confirmed that Wilson disease indeed is a rare disease affecting only 1 in 25,000 people. Most of his patients died young, as the disease was not understood and there was no treatment available. And it took more than 90 years ago till it became evident that the genetic defect causing Wilson disease indeed is a copper transporting protein. So let's have a closer look at that protein called ATP7B. In healthy individuals, ATP7B is responsible for two things. On one hand, it facilitates copper excretion into the bile so that the body can get rid of excess copper that has been taken up with the diet. This is important because copper in excess is toxic and can lead to organ damage. Secondly, that ATP7B protein mutated in Wilson disease leads to copper loading into copper enzymes, like the copper transporter in blood, called ceruloplasmin. Under physiological conditions, in healthy subjects, ceruloplasmin carries up to 6 copper atoms to their destination throughout the body, because a bit of copper is needed by every cell. But what happens in Wilson disease? Copper can't be excreted into the bile anymore, and thus copper is accumulating in the liver, and there leads to toxic damage and progressive liver failure. From the liver, the excess copper then spills over to other organs, especially to the brain, and causes brain damage, leading to dysfunction of motor function and may even cause psychiatric symptoms. Also, the second function of ATP7B is disturbed. There's no loading of copper enzymes anymore. And this becomes important later when we discuss diagnosis, because as the copper transporter ceruloplasmin cannot be loaded anymore, ceruloplasmin is rapidly degraded. And finally, in the patient, the liver copper is very high, while the copper in the bloodstream is low. And this is due to the fact that the copper transporter ceruloplasmin is low. The copper is still far too much in the body. And this is why the kidneys try to get rid of that excess copper, but they cannot really compensate for the disturbed function of the liver. But as a diagnostic finding, the renal copper excretion is elevated. The excess copper in the body leads to a variety of symptoms. I already described you that liver function is impaired and that patients have problems with gait and standing, and most of them develop a tremor. These neurologic symptoms may be very subtle and may be missing, especially in young patients. But also in other organs, various disturbances due to the toxic copper overload can be observed. This is just to show you that the spillover from the copper to other organs leads to damage there. But important is, the first step in that course of disease is a damage in the liver. And from that point on, later during the disease course, the other symptoms develop. So the typical Wilson disease patient shows liver symptoms first, and a couple of years later, neuropsychiatric disease. When we take into account what we now know about the copper metabolism, this is helpful when finding the right disease. Copper in blood, we discussed, is low. Ceruloplasmin in blood is low. And urinary copper excretion is elevated. Additional testing should include an extensive neuropsychiatric testing by an experienced neurologist, as well as a workup of liver function. It's also important to look for a special sign, the so-called Kaiser-Fleischer corneal ring. This is a deposit of copper in the outer membrane of the cornea, as shown here. This is easy to see as this patient has blue eyes, but imagine that it might be easily overlooked in a patient with brown eyes. So this is why it's so important that a patient where Wilson disease is suspected does see an ophthalmologist to get a proper exam of the eyes. As Wilson disease is a genetic disorder and the gene defect is known, it's additionally important to add genetic testing to the diagnostic workup to finally confirm the diagnosis. And as brain MRI becomes better and better over decades, it's important to look for changes in the brain as well. On the picture in the middle, right in the center, you can see a little sign called the smiling panda sign, showing changes that gives you the impression of a smiling panda that could guide the radiologist towards the correct diagnosis. Finally, there is a diagnostic scoring system available where all these parameters we already discussed enter. The presence or absence of neurologic symptoms or Kaiser-Fleischer corneal rings, ceruloplasmin in blood, liver copper, and urinary copper. Finally, confirmed can be the diagnosis by a proper mutational analysis. But the first and most important thing is to think of Wilson disease, especially in any patient with liver abnormalities and neurologic disorder. And when you've done that, the second important thing is, and this is also important for every patient, this is an autosomal recessively inherited disorder. So there's a likelihood of 25% for each sibling that he or she is affected as well. So this is why a first-degree relative of a Wilson disease patient should be checked for presence of the disease as well. Let me now briefly introduce you to the treatment options in Wilson disease. The first oral treatment was introduced in the 1950s with D-penicillamine by John Walsh. And a couple of years later, he introduced an alternative drug called trientine to help the patients. D-penicillamine and trientine are so-called chelating agents or chelators. They do bind copper and help with renal excretion of the excess copper. An alternative mode of action is evidently when looking at the third available treatment. This is zinc. Zinc does not directly interfere with copper, but it helps to block intestinal absorption of copper. So dipenicillamine and trientine help to get rid of the copper that's already in the body, and zinc prevents additional copper to enter the system. When we look at the overall treatment concept, when the patient is first diagnosed, he's fully copper loaded. So first thing would be to decopper the patient's and later on to prevent that additional excess copper is taken up again. Some of the patients present with so severe liver damage already at diagnosis, called acute fulminant Wilson disease, where only a liver transplant can save the patient's life. For the other patients, the medical treatment options are available. I already introduced you to dipenicillamine, the copper chelator. That was the first drug and still is one of the most important drugs to treat Wilson disease. Unfortunately, dipenicillamine comes with a couple of adverse events, some late, some early, that makes it necessary that any treatment is closely monitored by a physician. The alternative chelating agent, trientine, shows a better safety profile and seems to be equal efficient like dipenicillamine. This is a study showing you that the likelihood of experiencing adverse events under trientine is lower than under dipenicillamine. Zinc shows a different action as discussed because it induces endogenous chelators within the enterocyte. And when copper then tries to enter the body, it's trapped in the enterocyte. And the enterocytes are the first cells that come in contact with the content of the gastrointestinal tract. And these cells are renewed every 7 days. And they trap the copper, and the excess copper is not taken up into the body, but is excreted via the stool. Unfortunately, quite high doses of zinc are necessary to achieve that effect. This is why at least a third of the patients complain about gastritis and dyspepsia. However, for most of the patients, these treatments do an extremely good job. This is a study from the Czech Republic showing you that treated patients taking the medications have a comparable life expectancy compared to general population. However, and when we now come to the recommendation, this is something, the good outcome and the good life expectancy, that needs the attention of the patient and the physician. This is another study from Poland showing you the likelihood to develop new symptoms or to worsen, depending on whether you're compliant, this is the dotted line, or whether you're not compliant or adherent in terms of that the patients in the dotted line did not follow the prescribed regimen as good as the others. So the treatment in Wilson disease has to be lifelong. There's absolutely no condition or situation where the anti-copper treatment can be stopped. And the second most important thing to know is that when you start the treatment at a time point where there are no symptoms, then the patients will not develop any symptoms. This is important for example, the younger siblings of a diagnosed patient. When they start their anti-copper treatment right away from early childhood and they follow the drug regimen, these patients will at no time point suffer any symptoms of the disease. Let me conclude with two tables or lists. One is a should do, and the second one on the right-hand side is a don't do. The most important thing is, as a Wilson disease patient, to adhere to the treatment and to undergo regular checks with your healthcare provider. And the patient should see the doctor immediately if there are new symptoms, because this shouldn't be the case. And turning this around, it's uppermost important not to miss doses of the drug. Helpful might be as well to avoid high copper foods. And as an adult hepatologist, I may conclude by saying, remember, Wilson disease is a liver disease. Do not drink alcohol. Thank you for taking the time to listen to this presentation. And I'm happy if you contact me with additional questions.